Hi, I'm Joe Graydon.
I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy, where we bring you the stories behind the health headlines.
This podcast is brought to you by Redix Industries, makers of Utterly Smooth Body Cream. 800-345-7339, on the web at uttercream.com. Have you ever felt frustrated trying to explain troubling symptoms to a doctor? Were you interrupted mid-story? This is the People's Pharmacy with Terry and Joe Graydon.
Good communication between doctors and patients is crucial for proper diagnosis and treatment. How can patients make themselves heard? What should you do if you get interrupted?
Dr. Danielle Ofri has been writing about doctor-patient communication for years. She has some important advice.
Be clear as a patient what you need and what's important. And that if you're not getting that, to really ask for that and stand your ground.
Coming up on the People's Pharmacy, Dr. Danielle Ofri will share her insights from her latest book, What Patients Say, What Doctors Hear.
First, this news.
In the People's Pharmacy health headlines, couples that want children may be having more difficulty. A new meta-analysis shows that sperm counts among men around the world have dropped dramatically since the 1970s. The analysis included data from 185 studies with approximately 42,000 men participating in them between 1973 and 2011. According to these data, sperm counts declined by just over 50% in Europe, Australia, and North America. No similar drops were seen in Africa, Asia, and South America, but that may simply be due to a dearth of data for those regions. Nobody seems to know what explains the reduced sperm counts. Endocrine-disrupting chemicals in the environment may be one possible contributor. Studies are underway to try to determine the underlying factors. In the novel The Handmaid's Tale by Margaret Atwood, the premise was that fertility had been severely compromised. The book was written in 1985. More than 30 years later, this loss of fertility seems more plausible than ever.
Many Americans are distressed about the current level of polarization in politics. What they might not realize is that certain topics in medicine have also become quite polarized. One such is statin treatment for elevated cholesterol levels. Many cardiologists are adamant that statins are crucial for protecting people from heart attacks and strokes. They maintain that side effects are relatively rare and usually mild for most patients. Other cardiologists, however, point out that statin benefits are modest and side effects may be more common than clinical trials indicate. The latest salvo in this debate appears in the pages of the Annals of Internal Medicine this month.
A retrospective study evaluated the health of 28,255 patients seen at Brigham and Women's Hospital or Massachusetts General Hospital in Boston. All of these individuals had an adverse reaction to a statin cholesterol-lowering drug documented in their electronic record. Some of these people stopped taking the medication, although the majority continued on a statin. 4 years later, the researchers determined that 12.2% of those on a statin had experienced a heart attack, stroke, or death from any cause. In comparison, 13.9% of those who had discontinued their statin met such a fate. The difference between the two groups is 1.7%. The investigators state, continued use of statins after an adverse reaction may not be the optimal choice for everyone. However, an editorial in the same issue declares, statin denial, an internet-driven cult with deadly consequences. Editorialist Dr. Steve Nissen of the Cleveland Clinic notes, statins have developed a bad reputation with the public, a phenomenon driven largely by proliferation on the internet of bizarre and unscientific but seemingly persuasive criticism of these drugs. He points out that discontinuing statin treatment may be a life-threatening mistake.
Could extra calcium in the bloodstream increase the risk for a heart attack? That question arose after studies showed that people taking a high-dose calcium supplement appeared to be more likely to experience a heart attack. Epidemiologists from Sweden and the UK analyzed data from more than 180,000 individuals whose genetic data had been determined. Those with naturally high serum calcium levels were about 25% more likely to develop heart disease or have a heart attack compared to people with normal calcium levels.
When an older person falls, it can lead to devastating consequences. A broken hip, for example, may impair mobility or even put a person at risk for an early death. That's why a simple intervention to reduce the risk of falls is encouraging. A Spanish meta-analysis of 10 randomized controlled trials found that Tai Chi significantly reduced falls among elders. Tai Chi is an ancient Chinese martial art that features very slow, controlled movements and improves balance. In this analysis, people practicing Tai Chi were 43% less likely to fall in the short term than people who did physical therapy or other low-intensity exercise. Long-term follow-up showed that Tai Chi practitioners were 28% less likely to suffer a serious injury if they did fall. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Grayton.
And I'm Terry Graydon. Communication between doctors and patients is at the heart of healthcare. It's essential for accurate diagnosis. Also, patients need to understand the treatment being offered so they can follow it correctly.
That sounds simple, but it's not easy. Doctors often feel pressured for time, and that may interfere with their ability to really listen.
Today, we're talking with Dr. Danielle Ofri. She's a physician at Bellevue Hospital and an associate professor of medicine at New York University. She's co-founder and editor-in-chief of the Bellevue Literary Review and author of What Patients Say, What Doctors Hear.
Dr. Danielle Ofri, welcome back to the People's Pharmacy.
It's great to be here.
Dr. Ofri, your brand new book is titled What Patients Say, What Doctors Hear. Why is there a difference?
Well, I think that most people listening probably have had that experience and intuitively know that there's always a difference. But how this book in particular came to be is that I interviewed a doctor for my previous book about what doctors feel, about doctors and patients becoming friends outside the office. And I came to notice on this doctor's blog that a patient had been commenting, turned out to be the patient in question, who agreed to talk as well, and interview the patient. And it turned out that they told entirely different stories. Even though both were intelligent, thoughtful, introspective people, they saw things completely different, almost like a scene in a movie with two different movie cameras. And at times it felt like almost two different movies altogether. And that then became the kernel of this book.
I wonder if you'd tell us about that patient and her doctor.
So the patient was a young woman who had some very complicated symptoms that didn't fit into an easy picture. She was a, quote, difficult patient, the kind who has lots of things that don't add up, who's very actively involved in her care, comes in with 50 questions, almost, wants to direct the show. And you might say very empowered patient, but can be challenging. And many doctors didn't want to take her case because it involved so much work. And this doctor who took it on was a very well-known, excellent doctor. But they really clashed over the direction of the care. And this patient was willing to try anything. She really felt that her life was at risk, and she was willing to push the envelope. And the doctor was very concerned about toxic treatments. At one point, the patient wants a bone marrow transplant, a very, very aggressive treatment. And the doctor thought that this was a poor choice that could really harm the patient. And they really clashed. And in telling their stories, they both respected each other, even liked each other, but saw it very differently. The patient wanted to do whatever it took to try and achieve good health. The doctor did not want to be harming the patient, and so they had a complete disagreement and eventually had to part ways.
Well, speaking of difficult patients, you start your book with a story about Mr. Amadou. And he, too, was a difficult patient, and you came to regret your way in which you were interacting with him because of a pretty dramatic experience. Could you share that with our listeners?
So Mr. Amadou was a young man in his 40s from West Africa, but he had a serious heart condition, even at such a young age. And he was a very demanding type of patient. He called all the time, and he always needed something, a form filled out, a medication renewed, and whatever he needed right now. There was a very demanding feel for him. Although he was a lovely person, he was just, he was, quote, high maintenance. He just always needed my time. And he called me once saying he needed to see me. He didn't feel good. And so I tried to figure out, does he need to be seen right away? Could this wait for an appointment? And I tried to get him to come to our urgent care or walk-in, but he wouldn't come. He only wanted to see me. And we kept trading messages. And I was getting increasingly frustrated with him. If you're feeling very sick, come to the urgent care or come to the emergency room. If you're not feeling so sick, then wait for an appointment like everyone else. And he would keep coming back saying, I just need to see you, Dr. Ofri. I won't see anyone else. In the end, he sort of pops in without an appointment, asking to see me. And I felt very torn because if I give in and let him come in, he sort of figured out, okay, just be persistent and I'll eventually cave and he can just walk in and get an evaluation whenever he wants. And I really tried to draw a line in the sand. But he also had a very severe heart condition. I said, okay, this one time, come on, let me take a listen to your heart and lungs. And he smiled and I think, oh boy, I've really sunk myself here. He's always going to be coming in without an appointment. As he walks in the room, he collapses right on the spot, falls down, his heart, and I can't get a blood pressure, I hardly can get his pulse is racing. I bring him to the ER, and I'm, of course, overcome by guilt. Here I was arguing with him over 2 weeks about an appointment when, in fact, he had a very serious condition going on. And I really thought about why we had so much trouble communicating. I don't think that he was right or wrong or I was right or wrong, but I was really seeing him as the difficult, demanding patient. For him, he was seeing it as this was his life, and he had to do a little bit like the other patient, whatever it took, even if it was being a little over the line in terms of what might be perceived as rude sometimes. And we just weren't really hearing each other that well.
And, of course, the fact that he is West African may also add a cultural difference to the whole mix as well.
That's true, and I'm so privileged to work at a hospital like Bellevue Hospital, in which most of my patients come from other countries, and I'm always learning about new and interesting cultures. But yes, there may be a different way that he's used to dealing with the medical system. And for him also, he was speaking not his first nor his second, but his third language, English. And usually we use French interpreters with West African patients, but even that is not a first language for most of them. So there are challenges just within the language, but also in the way we approach things. And in America, we have a certain way of the expectation of how you behave, between doctor and patient. And it may be different where he's from, and I wasn't aware of that.
Analyzing communication between doctors and patients can be complicated. And I'm hoping that you'll tell us about Deborah Roeder, a researcher in communications who worked out a methodology for actually figuring out what's going on in an interaction between a doctor and a patient.
It's interesting. How do you measure communication? You can't take a blood pressure or temperature. So what people typically did is you would record a conversation, and then you would sit and transcribe every single word that's spoken and then try to analyze what's there. As you can imagine, this is very labor-intensive. So most research in communication was always with small numbers of people. You couldn't do a whole lot. What she figured out was a way to classify conversation while listening to it, instead of having to transcribe every word. So she came up with a way of categorizing every unit of speech. And so, for example, a researcher would listen and classify a statement as, is it a question? Is it a statement? Is it a request for information? Is it an education? Is it a statement that is developing empathy in relationship? It is a statement of confusion. And is it a statement of support? So she came up with a host of several dozen categories in a way that a researcher rather quickly could come up with an analysis of conversation. What percentage of the time was the doctor expressing support for the patient? How many times did the patient have to repeat a question until they got an answer? And you could see how the different conversations broke down. And then with that tool, you could then study different types of communication with outcomes. So, for example, you could analyze, well, how many questions does a patient ask? Or how well do they get answered? And then how well is the blood pressure controlled? Or how well do they take their medications for HIV? And this then opened the door to an enormous amount of communication research in which we can now quantitatively look at the elements of communication and how they correlate with health outcomes.
Well, speaking of research, the amount of time that's available during a patient-doctor interaction has been reduced over the years. Go back 40 years and, a family practice physician might have 15, 20, 30 minutes to interact with the patient. Now we hear it can range anywhere from about 7 or 8 minutes to maybe 12 to 14 minutes. Doctors feel rushed. Patients feel that the doctor is rushed. And so there's this sense that patients will be interrupted rather quickly. In fact, the Swiss researchers have found that patients may only get to speak for a minute to a minute and a half to tell their story. And we often hear that doctors will interrupt patients after 15 or 20 seconds, sometimes even less. So I'd like to get your sense of how patients can tell their story, how physicians can listen to that story without interrupting.
Well, it's interesting, the data. So the data show that doctors interrupt within 8 to 10 seconds. So very quickly the doctor jumps right in to steer the conversation. And the Swiss study you cited was a study in which they decided not to interrupt the patient, let them talk as much as they want. And in fact, they only spoke about 90 seconds, which was a message, I think, for we doctors that we could actually step back and let patients tell their story when we won't be overwhelmed by patients talking for 20, 30 minutes or an hour. So for me as a doctor from that study, I've tried very hard to withhold the impulse to jump right in and let the patient talk. And usually the patient will come to a natural end and we still have enough time. I agree with you that the physical amount of time has gotten shorter. Add in also that doctors now have to do many, many more things in that short amount of time. So I was in the hospital today seeing patients, and with our new electronic medical records, there's many more fields to fill in. And electronic prescribing, it takes a long time. Even though it's a time saver perhaps in the end, it's not necessarily in the moment. So I think that patients could at least recognize the reality that doctors they're forced to multitask. It's simply not possible to not multitask. And of course, multitasking runs the risk of less focus. So for the patient, though, even with that, I think the patient needs to expect that they'll be able to tell their story. And if I can step back one moment to the idea that both doctors and patients need to recognize that the doctor-patient conversation is the most important diagnostic tool. More important than scans, blood tests, more important in treatment often than the medications themselves. And so to give that its due and not to rush past it to get to the blood test and the CAT scan.
You're listening to Dr. Danielle Ofri, Associate Professor of Medicine at NYU. Her book is What Patients Say, What Doctors Hear.
After the break, we'll learn what patients can do to help make communication clearer. Why don't patients always hear what their doctors say?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you like the information you hear when you listen to The People's Pharmacy, you may also enjoy our book published by National Geographic. It's The People's Pharmacy Quick and Handy Home Remedies, available online at peoplespharmacy.com or at your favorite bookstore. Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. 800-345-7339, online at uttercream.com.
If you would like to purchase a CD of this show, you can call 800-732-2334. Today's show is 1088. That number again, 800-732-2334. Online at peoplespharmacy.com. You can also download the podcast from iTunes.
Today, we're talking about communication between doctors and patients. This seems like such a simple matter, but it's full of pitfalls. Do doctors need to learn to squint with their ears to really understand what patients are trying to say?
To help us better understand the potential problems that can arise and how to overcome them, we're talking with Dr. Danielle Ofri. She's a physician at Bellevue Hospital, the oldest public hospital in the country. She's also an associate professor of medicine at NYU who's written many books. Her most recent is What Patients Say, What Doctors Hear.
Dr. Ofri, I'm wondering, given the time pressure that we recognize and the importance of the patient being able to tell his or her story, what can a patient do to make this work better?
Well, there's always the time, honored advice that the patient should come in with a list of topics or questions, and I think that's very important. But it's also critical to be realistic. Very often a patient will come in with, 35 questions written out, and the truth is if you're trying to do all of that, you'll never get beyond the superficial. So be realistic and expect to cover 2 or 3 things in a visit. There's no way you can do 15. And maybe you want to pick what's most important to you and ask the doctor what's the most important to them, because they may pick out something that's critical, but maybe you don't realize that. The second thing for patients to at least be aware of is the difficult pressure their doctor is under. There's simply no way for the doctor to do all they're asked to do in that time period. That does not excuse a doctor not to listen. And a patient is very well within their rights to say, hey, give me a minute and I'll tell you my whole story, and then we can go on. If the doctor doesn't let you tell that story, you really need to demand that because that's critical.
We've heard many times from physicians that, they've had this complete interaction with the patient. The patient has gone through, several questions. There's been, the physical exam, the recommendations, the prescription, and the doctor has his or her hand on the doorknob, ready to leave the room. And the patient says, oh, doctor, one more thing. And that turns out to be the biggest elephant in the room because, I've been coughing up blood. And they just waited for the doctor to be heading out the door to mention this disaster waiting to happen. How can we get patients to prioritize so that the biggest, most important question is not the one more thing as the doctor's leaving?
So that, I think, falls on the doctor. One, to give the patient some time to talk in the beginning. Again, even if it's just a minute, but a full minute in which you listen intently and with good focus is actually quite a lot. Not only do you get better information, but you create an atmosphere of trust. And I think that often what happens on the hand on the door is often things patients weren't comfortable revealing earlier. And maybe it's domestic violence, maybe it's an eating disorder, maybe it's sexual dysfunction, things that are more awkward to talk about. And so creating a more comfortable environment right from the start is helpful. The other thing for the doctor to say when they get through with the main issues, is there anything else? And although doctors hate to do that because it may bring up 10 more things, I find that often just by telling patients there's a chance to say whatever else you need to say is more reassuring. In fact, fewer things come up if I offer that opportunity.
You write in your book that doctors need to be fully focused, and you describe this in a way that I think is so brilliant. You say, squinting with my ear. Can you explain what you mean?
We have to listen very hard because it is true that some patients know exactly what's going on and what bothers them, but many patients don't. It'll just be a vague feeling, or it'll be a psychological issue that manifests itself with a physical symptom, and it can be very hard to pick out what's really going on. And if we're only listening with half an ear and we're busy typing or trying to get the computer to work or unclog the printer, we're not really hearing. And so often, the real issue is hidden under a few layers. And I make the analogy, I've been taking cello lessons for the last few years. And when I started playing cello, having come from the piano, Piano's kind of easy. There's a C and it's always in the same spot. But in a stringed instrument, you have to find where the note is. There's no marking. The only way to know that it's there is when your ear says, aha, you've got a C. And that took and continues to take a lot of work. And I have to focus. I can't do it if my mind is elsewhere. I have to focus really 100%. I really have to squint with my ears. And I often think that with my patients, I have to squint with my ears also to hear precisely what's going on.
It sounds as though that's really critical for making an appropriate diagnosis.
Oh, I'm sure that the rate of medical error is directly related to the amount of listening that we do. When it comes to malpractice suits, if you look at the reasons that patients sue, in fact, true medical error is a very small percentage of lawsuits. Most of them come from not being able to get information or not being treated well or the sense of being disrespected. And so given that, and of course we should be focused on minimizing medical error, that's an enormous area of intervention. But there's a whole large part of the iceberg, and I think it's the part that's really underwater, in that the reasons that patients are upset and sue is because they haven't been communicated with appropriately and respectfully. And that we can control. I think it's not that hard, in fact. And patients do want to know what's going on, and being able to convey that and letting the patient know that there's always a chance to ask another question. And if there's an error, that I will tell you, I'll be honest with you. And most patients are less likely to sue, even in the face of an error, if the doctor's been open and honest with them.
There's research to back that up, isn't there?
And there certainly is. And if you look, interesting, this is in simulated studies, but the question was whether a patient would want to switch to another doctor if there was an error. And when the doctors fully told them about the error and honestly acknowledged and apologized, the patients, in fact, didn't want to leave their doctor because they felt, now I know I can trust this doctor. Because the doctor revealed the error, I know I can be safe with them. Because if anything happens, I'm in good hands. I won't be lied to. And so that kind of honesty, in fact, enhances the doctor-patient relationship, not undercuts it.
Let's talk a little bit about medical error a little more, because we have recently seen a couple of different studies. One was published in the JAMA Ophthalmology. Another one was published in JAMA Pediatrics. Both of them described a study in which in the case of the pediatrics, what the parents told the doctors did not end up showing up in the medical record all the time. Sometimes it would, but not all the time. And the similar situation happened in the eye clinic that was published in JAMA Ophthalmology. Patients came in, they were given a sheet to write down their symptoms, and these symptoms didn't always end up in the patient's record. It gives us the impression that perhaps the healthcare provider is not paying as much attention as ought to be paid.
Well, I look at the amount of information that's being thrown at the healthcare provider. For example, when I was prescribing medications this morning in clinic, for every medication that I prescribe, there are about, I'm going to say 5 or 10 alerts come up. Different interactions, different things to be aware of. And if a patient is on 10 medications, that's maybe 50 notices to see. Now, of course, there's so many that I can't actually read them all in the depth that would be required, so we end up tuning them out. And the same thing often with these sheets. Patients are given all these things to fill out, and you're handed a stack of papers. Many doctors end up not reading them. They probably should, but realistically they often can't. So part of it is the setup of the system. We have all these systems in place purportedly to give better information, but like the medication alerts, we give so many that they end up falling by the wayside. So it may be that the written information in advance is not the way to do it, but in fact the doctor needs to ask directly what's going on and get that information directly there. But you're right, we don't often see everything around us, and that can be that we're distracted, we're focused on other things, we're overwhelmed, or people are burned out. So this kind of cycles back to looking at the sort of emotional health of everyone involved in the interaction.
Dr. Ofri, I'd like to talk a little bit more about honesty and trust. When I was a young child, I was in the hospital with polio, And people in white coats and masks did some pretty unpleasant things to me. And I also had to have several surgeries later as a child. And whenever I would ask, and I almost always did, will this hurt? I was always told, inevitably, no, it won't hurt. But it always did. And sometimes it hurt a lot. And the idea that, I understand the doctor was trying to reassure me, or the nurse, this was a procedure that they had to do. And, if they said it will hurt, then maybe I wouldn't cooperate. But in the long run, it sort of a boomerang because they lost my trust. Could you talk a little bit about that?
I think there's two parts to your question. One is absolutely the trust. I think once trust is eroded in terms of honesty, it's very hard to earn it back. But the second is the power of the words. And your doctors, I think, squandered an opportunity to use their words. And I'll cite just briefly an old study from 1964 in which patients were going for abdominal surgery. And as you know, there's a lot of post-op pain after surgery, and it can be very, very devastating. And patients end up needing narcotics, which are strong pain medications with many devastating side effects that range from constipation and nausea to addiction and death. So cutting down opiates is very high priority. So in this study, the night before, the anesthetist goes to talk to the patient as per usual about the surgery. But in half the patients, the anesthetist added a 20-minute discussion about pain. They talked about what the pain is caused by, clenching muscles, when to expect it, what it might feel like, how long it might last. Here are some exercises to relax your muscles that might relieve the pain. If those don't work, here's how to call the nurse. Here's what you might get. Here are the side effects. The next day, the surgeons operated. No one knew who got the extra discussion. And those patients, as you might imagine, had less pain. In fact, they needed half the amount of narcotics that the other patients just by that 20-minute conversation. And furthermore, they were discharged from the hospital 3 days earlier, all from a 20-minute conversation about what to expect with the pain. So it's not just being honest, although it's very important. It's also that addressing directly what the pain will be just by itself lowers patient anxiety, helps them know what to do, and that alone could do so much.
Dr. Ofri, it's not only what patients say and what doctors hear, it's also the other direction, what the doctor is saying, what the patient hears. And you tell a wonderful story about a young woman, Tracy Pratt, who is having a very difficult time controlling her diabetes. She's not doing what her doctor is telling her. Why not?
It's a fascinating story of, again, a wonderful doctor and patient. And I was really privileged to interview both of them. And the two of them also ultimately did a public conversation about their experience together. And a wonderful doctor who really wanted to help the patient, and a wonderful patient who was smart, thoughtful, and yet she had many things in her life beside diabetes. But from the doctor's perspective, the diabetes was the most important, and every visit was about diabetes. And so when she came to the doctor, she had other things in her mind as well. But it felt like no matter what, she could come in for a pulled muscle or back pain, and the talk was about diabetes and your weight and your diet. And it felt like it was an attack on her abilities. And she began to pull away from the clinic. And even though the doctor was trying so hard to connect with her and really wanted to help her control the diabetes, she really couldn't hear it. And ultimately, she pulled out of medical care entirely, ended up in the hospital with very serious complications of diabetes. And as they spoke about it together later, they really recognized that each had their own agenda. And not that anyone was right or wrong. They both were appropriate and correct agendas, but they were not talking on the same plane with each other.
Speaking of not being on the same plane, there is a kind of attitude by, I think, a number of health professionals that some patients are non-compliant or non-adherent, which is a little more sanitized. And it's the idea that, well, this is a difficult patient. This is a bad patient. This patient isn't doing what I want him or her to do. And I'd like to share a story with you that we received on our website not too long ago. This patient says, I've been coughing for about 7 months now. I've been given 2 inhalers, cough medicine, prednisone, and an antibiotic. I've had a sinus CT scan and a chest x-ray. I've been to an allergist. I have an appointment with a pulmonary doctor at the suggestion of my primary doctor and allergist. I finally realized that my blood pressure medication had been switched 7 months ago. All my doctor said was, oh yeah, it does cause coughing. I'm losing sleep, feel like I'm coughing up a lung, gagging, sweating, have dry mouth and throat. I'm tired of being prescribed other medicines that have nothing to do with this cough. I feel like I'm keeping the cough drop industry going. I eat so many of them. I don't feel like my doctor thinks it's a serious problem for me, and I'll be looking for a new one. This is all regarding a blood pressure medicine called lisinopril, an ACE inhibitor. Your thoughts about this interaction?
I think it's sadly very, very common. And there was a wonderful study done about adherence to medication for diabetes. And this researcher, Heidi Hamilton, looked at videotapes of doctors and patients, and then each were interviewed separately after the visit. And what was interesting is that the doctors never understood why the patients weren't taking the medications appropriately. Yet the patients knew, but they only told the interviewers afterward, when they're not with the doctor, what the real problems were, whether the medication was too expensive or caused side effects or it was embarrassing or there was family pressures to eat, the family food, because the doctors never really asked. They, just said, you better take your medication, otherwise you're going to end up on dialysis or with amputations. And what I took from that is I now ask my patients, not just are you taking your meds, but what's the hardest thing about diabetes? Or I'll say something like, many patients have difficulty with the medications. Are you having any trouble with them? Because there are things that are beyond just the yes-no of taking medications. And in the story that you related, it seems like the doctor did not do a very careful history, because they should really know that lisinopril can cause a cough. And it maybe they rushed right past that or didn't even notice because they were so busy getting down to the treatment plan as opposed to the listening part. And that's a diagnosis that could be made in conversation. You wouldn't need any CAT scans to make that diagnosis.
You're listening to Dr. Danielle Ofri, author of What Patients Say, What Doctors Hear. Dr. Ofri is Associate Professor of Medicine at New York University and a physician at Bellevue Hospital. She writes about doctors, patients, and medicine for the New York Times and is co-founder and editor-in-chief of the Bellevue Literary Review. She has a monthly newsletter and a website, DanielleOfri.com. That's OFRI.
After the break, we'll find out how doctors can get past some of their own biases.
How can they change their inner landscapes?
Should you try being a bad patient, speaking up and complaining when something's wrong?
You'll learn how a chief listening officer made a big difference for a healthcare organization and its patients.
How can we all learn to communicate more clearly?
You're listening to The People's Pharmacy with Joe and Terry Graydon. If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com.
Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red-X Industries, makers of Utterly Smooth Foot Cream with shea butter, helping dry, cracked feet feel utterly soft and smooth. 800-345-7339. The website is uttercream.com.
To purchase a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is 1088. That number again, 800-732-2334. Or you can download the free podcast from iTunes or from our web store. We invite you to consider writing a review.
Today, our topic is communication between doctors and patients. This is absolutely crucial to the practice of medicine, and yet it's easily derailed. Besides language barriers, time pressure and cultural differences can get in the way of people understanding each other. How can doctors open their hearts and their ears to understand what their patients are trying to communicate?
To help us bridge the divide, we're talking with Dr. Danielle Ofri. She's a physician at Bellevue Hospital. She's also an associate professor of medicine at NYU who's written many books, including What Doctors Feel, How Emotions Affect the Practice of Medicine, Intensive Care, A Doctor's Journey, and Medicine in Translation, Journeys with My Patients. Her most recent work is What Patients Say, What Doctors Hear.
Dr. Ofri, it seems that how an interaction evolves can make a difference. And you tell the story in What Patients Say, What Doctors Hear about a patient of yours, Anita Lyons. Would you tell us about that interaction, please?
So Anita Lyons was a new patient that I saw, a relatively young woman in her 30s who was severely obese, very overweight, to the point where she could really hardly walk. And I really could not do a physical exam. And I remember thinking if it was a very uncomfortable interaction. I have to admit, it was physically hard to do the physical exam. Her life seemed so out of control. It was very hard to find an area to connect with her. And I remember during the conversation, the phone rang. And she was apologetic, but it was a teacher for one of her kids. And I said, no, please go, take the phone call because I know how hard it is to get in touch with teachers. And I remember hearing her have this conversation and identifying very much with her because I have 3 kids and conversations with teachers are important. They can be difficult. They can be a little uncomfortable. And as she spoke, it very much humanized her for me, that I really related to her. And I thought about wanting to share that mutuality that we had. But then I wondered if that would really be helpful. And in fact, there was a study that showed that doctors who choose to reveal personal information, in many respects, that can actually be harmful to the relationship because it takes even though it's done with good intention, it often takes the focus off the patient themselves, rather than keep the patient front and center. In the end, I elected not to share that, but in my head, I felt that connection, and it was definitely easier to relate to her after that.
Well, speaking of stigmatization, I mean, I suspect that physicians are, they're human like everybody else, and so when somebody comes into the office and they're overweight, or maybe they smoke, or perhaps they've got a mental illness and you're not a psychiatrist and you're sort of like, wow, this patient is just so anxious and driving me crazy. It can sometimes be hard to empathize. How do we help physicians get past some of those barriers?
Well, I think we have to be honest with our own biases. And with Ms. Lyons, I had to confront the fact that her obesity made me uncomfortable and that I really wanted to look at that. And that I really wanted to recognize that maybe I wasn't being as neutral and open as I might have been, and I had to really hold that up to the light for myself and say it's not acceptable. It's really not. And I think that, yes, we're human. We do this also. And recognizing that we do have thoughts that are unappetizing about our patients. We may have racist thoughts or sexist thoughts. We may come to prejudgments about mental illness. And part of it is being honest with ourselves, that noticing where our blind spots and where our imperfections are and recognizing that we have to say, you know what, it's not okay. My gut may be saying this, but I need to override that because my goal is to give good care and respectful care for everyone. And I try it when I'm stuck in a situation where I feel uncomfortable for whatever reason. I try to say, what if that person were my parent or my grandparent or my child? And let's say they were a difficult or angry person or malodorous or some other thing that made it uncomfortable. How would I want them to be treated? With empathy. And we often have to push ourselves to get, past our biases, but it's absolutely critically important.
Dr. Ofri, you've written something that I'm hoping you'll be able to explain to us. You wrote, modifying our external behavior and how we communicate is clearly important. But I believe we in the medical profession have a duty to work to change our inner landscapes as well. What exactly do you mean by that, and how might it change things?
So there's the phrase from psychology called to act, quote, as if. So if you're in a situation where you're uncomfortable, let's say you're uncomfortable with someone with blonde hair, okay? And when you get in the situation with someone with blonde hair, you don't respond as well. So one thing you can do is to act as if blonde hair does not bother you. And at least externally, that person shouldn't be feeling your bias. Now, often, if you do that enough, your bias will, in fact, start to melt away because you'll see that, people with blonde hair aren't so bad. Also, your behavior can be a model for others and contagious. Respect can certainly be contagious. But I think then we're also obliged to confront what is it about blonde hair, or you can fill in the blank, obesity, race, religion, that makes us uncomfortable. Why is it that someone with a name that brings up a certain thing to mind puts us on edge? Do we have a reason for that? Because again, as medical professionals, we owe our patients respectful, genuine care. We can't just pretend to overcome our biases. We really need to actually work on overcoming our biases because that's the best medical care that we can give our patients.
Dr. Ofri, how do we help patients become bad patients? Now, what I mean by that is I think there are a lot of people who, when they go into that exam room or if they're in the hospital, they want to be good patients. They want to be perceived as nice people. They want to be cooperative. And that's especially true when you're feeling powerless in the hospital. They've taken away your clothes. Your family may not be able to be there 24 hours a day. And, something happens and you're uncomfortable with it. You don't want to complain or complain too much because then you'll be labeled a bad patient. But sometimes speaking up for yourself, complaining, that may actually be important, might even save your life.
It's true, sadly. And I think we need to reorient in that we don't define that as, quote, bad. And I think we can distinguish. There are patients who can be, obnoxious, but you can also be assertive, but also be polite and respectful. And I think that finding that line is not as hard as it seems. So be clear as a patient what you need and what's important. And that if you're not getting that, to really ask for that and stand your ground. You don't have to be screaming at the receptionist who has no control or going over people's heads, unnecessarily. But if you need to, call the patient advocate office, ask to speak to a supervisor. But if done, politely and nicely, and to not make it personal. I think often when we get in a situation where we're frustrated, we make it very personal and yell at the person in front of us, and that, of course, never gets us anywhere. So having sort of the twin pillars of, be easy to work with, but also be firm in your convictions and what's important.
I'd also like to ask about assumptions, because there are a lot of physicians who they will put out a scenario or they'll make a recommendation and the patient says, no, thank you. I don't want to do that for whatever reason. And the doctor's thinking, wait a minute, this is so logical, so appropriate. In fact, you tell a story about a woman who had a mom with mental illness, and she was diagnosed with cancer. She was, I think, in her early 60s. And the doctor said, well, we'll treat her with chemotherapy and we'll extend her life. And this woman said, well, I don't think she'll want that. And the doctor said,
actually, it was Corina, and she said, did you ask her if that's what she wanted? She didn't speak for her mother. So how important is it to actually ask the patient, him or herself, what is it that you want?
Well, that's, I find, so often when patients, quote, refuse treatment. We write it that way, the patient refuses, or the patient is non-compliant with the treatment. But instead, if we ask, what are you most concerned about? What do you think the treatment's going to do? And what do you think will happen if you don't do it? And I'm often amazed at the answers. It's often quite different than what I expected the answer to be. And in this case, the mother in question had a very difficult and painful life. her mental illness was overwhelming. And in fact, she tried to kill herself many times, and she did not want to live. And extending her life turned out to be what she did not want. And in fact, the cancer allowed her a peaceful end to a painful life. It might not be what most of us would want, but it turned out to be what she wanted. And our reflex as doctors is to say, well, this is the right thing to do. And rather than say that up front, just to see, what's important for you. What's the most important thing for you, and what are you most worried about?
Dr. Ofri, that story is part of a chapter about a woman named Corina who eventually had a position in a hospital, this was in the Netherlands, as chief listening officer. This fascinates me, the idea that someone would be a chief listening officer. What did she do and how did it work?
Well, this hospital was in a crisis. There had been very high mortality rates in one of the surgical departments, and the department was closed down. And they decided to sort of reshape the whole hospital. And Corinne had been doing work for a radio station who needed to find out, what their customers were interested in. And rather than do a typical survey, she actually went house to house and asked people and talked to them. And she found that people were so interested in telling their story about what's important to them. And so the hospital ended up hiring her to do this for their patients. And her job was only that, to listen. She didn't have to recommend a plan, mediate anything. And so the first case that came up was in the oncology department. And the younger oncology patients were very unhappy with their situation. And so she went and spoke to them for hours at a time, at home, in the hospital, in the chemotherapy suite, in the doctor's office, to find out what was really, really on their mind. And it turns out they weren't upset about their actual medical care, but they were so overwhelmed with their illness. No one talked to them about, if you could have sex while you're on chemotherapy, or how to tell your coworkers at work or your professors in college that you have cancer. All these things that made up their day-to-day life weren't being addressed at all. And the hospital really had no idea that this was really what was on their patients' minds. And so she was able to compile a report about the patient's real concerns. And the idea of a chief listening officer kind of turns things on their head, lets patients just express themselves, and will often hear things quite different than what we think is most important for them.
In fact, it fascinated me also that the Dutch government decided that doctors should be reimbursed for listening, at least in certain situations.
The U.S. health insurance system, it was developed around the idea of fee for service. And a service is usually a procedure, a tube, an orifice, a surgery, a CAT scan, MRI. It doesn't really think about the conversation as part of medical care. But in fact, as we are learning, that is, again, the most important part of the medical diagnosis and often of the treatment. And certainly in patients with chronic illnesses, which are the majority of our illnesses today, diabetes, heart disease, depression, obesity, what the most important part of the medical care is the conversation about lifestyle, eating, taking your medications. It's very little about surgeries and procedures. And as such, though, our insurance company doesn't really value that or reimburse for that. So, of course, we're much more likely to do procedures. The Dutch government recognized that the conversation part is quite valid, and so they began at least by funding discussions about advanced directives, end-of-life care, what would you want? Because this ultimately saves so much money down the line because patients work out in advance what's important for them.
Dr. Ofri, I wonder how we can all, patients and healthcare workers alike, learn how to communicate more clearly, and what should we be taking away from this conversation and your book, What Patients Say, What Doctors Hear?
The first thing I would say is to recognize, again, the conversation as being of value. And so to put some time and effort and planning into it. So for the patient to really think about what are your priorities. Don't just go in blindly. Think in advance what's important to you. What do you need to know? What is your goal here? Because that goal may be different from your doctor's.
Dr. Ofri, what would you really like patients and their families to take away from this wonderful book of yours so that there will be enhanced communication between doctors and patients going forward?
I'd like patients and families and doctors to come to the visit thinking that the most important thing we'll do today is our conversation. It's our talking. Let's give that the most time and attention and focus. Not look at it as just sort of an affable bedside manner, but that's the meat of the visit. And sure, we'll do a physical exam. That's important. We'll do some blood tests maybe. But really give our respect and due to the conversation, because that's where the information comes. That's where the diagnosis is made. That's where errors can be made or prevented. So let's put our most effort into that conversation.
Dr. Danielle Ofri, thank you so much for talking with us on the People's Pharmacy today.
Thank you.
You've been listening to Dr. Danielle Ofri, author of What Patients Say, What Doctors Hear. Her previous books include What Doctors Feel, How Emotions Affect the Practice of Medicine, Intensive Care, A Doctor's Journey, and Medicine in Translation, Journeys with My Patients. Dr. Ofri is Associate Professor of Medicine at New York University and a physician at Bellevue Hospital in New York City. She writes about doctors, patients, and medicine for the New York Times and is co-founder and editor-in-chief of the Bellevue Literary Review. She has a monthly newsletter and a website, DanielleOfri.com. That's spelled O-F-R-I.
If you're a patient, we'd like to hear how you tell your story to your healthcare providers. What challenges have you faced, and how have you overcome them? If you're a health professional, how do you listen to your patients? We'd love to have your perspective. Go to the comment section of today's show at peoplespharmacy.com.
Lynn Siegel produced today's show. Al Wadarsky and Russ Henry handled the engineering. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible by Redx Industries, makers of Utterly Smooth Extra Care 20 Cream with 20% urea for extra skin protection. The number's 800-345-7339. The website is uttercream.com.
If you'd like to buy a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1088. You can also find it on the website peoplespharmacy.com.
When you visit our site, you can check out information on prescription drugs, herbal medicines, and home remedies, share your thoughts on today's show, and share your story.
At the website, you could also sign up for our free online newsletter or the free podcast of the show. Listen at your own convenience or share it with a friend. We'd certainly appreciate you rating our podcast at iTunes, Google Play, or wherever you subscribe.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.
When it comes to Father's Day, some things never change. Dads want steak. And the experts at Omaha Steaks are making it easy for you to deliver uncompromising quality with gifts that are sure to make his day. Plus, get an extra $35 off with code THANKSDAD when you shop omahasteaks.com today. We know being your dad means he already has everything he could want. But just picture the look on his face when he sees those extra-aged USDA-certified tender steaks, juicy air-chilled chicken, beefy burgers, and more. With carefully curated gift packages from America's original butcher, it's never been easier to show everyone why you're dad's favorite. And every bite is 100% guaranteed to bring a thrill to the king of the grill. Shop now at omahasteaks.com and get an extra $35 off with code THANKSDAD. But don't wait. Father's Day is June 15th. Minimum purchase may apply. See site for details.